our wonderful fellows on the spine side will present highlights of their research. Everybody will have about 5 minutes time to present, and we'll have roughly about 5 minutes of discussion. Just to give you a framework, these are all ongoing research projects that are either being submitted, so they're red hot off the press, or in the final stages of completion. And our fellows have worked very hard on this for all year long. They're absolutely wonderful. We will try to put in 10 speakers, 10 different speakers. 3 of them are mystery guests as the course of the day goes on. One of our fellows, Dr. Elias, sadly isn't here. He's on a vacation leave right now. So you'll see 6 of the fellows. The other 4 will be mystery guests that I'll introduce as the day goes on. Without much further ado, I'll ask the first of our speakers, Dr. Paul McBride, and I'll ask them all to briefly introduce themselves also and tell us where they're going next. And all of them will have, as you see, research subjects that range from very technical, clinically focused things to large-scale epidemiologic studies. So we're proud of all of them and congratulate them on their work. Dr. McBride will take the first lead, and he'll talk about something that's very near and dear to our heart, and that is how do we manage the junctional areas above fusions if there's a possibility for a stenosis evolving. Dr. McBride, thanks for all your hard work. Welcome.
Thank you, Dr. Chapman. My name is Paul McBride. I'm a neurosurgery resident at USF in Tampa, Florida. I'm here doing an enfolded fellowship at Swedish. I'll be starting off with the paper that I'm working on, still currently in process of working on. It's called, working title now is a posterior ligamentous complex integrity at the cranial segment of lumbar instrumented fusion and its effect on adjacent segment disease. This is a retrospective review study. So when I sat down to come up with a research paper, I originally wanted to work on doing a laminectomy above a fusion. But as I thought about it more and started doing some literature review, I realized that the important thing really was the ligamentous complex between the UIV and the UIV +1. It doesn't make much difference if you do a full laminectomy at the UIV versus taking the inferior laminectomy of the vertebrae above the fusion or any higher than that. It's really just that connection that provides you that posterior tension band between your fused and your unfused segment. So I sort of morphed the project into more focusing on that segment specifically. And so the thought being that if you preserve the posterior ligamentous complex between the UIV and the UIV +1 in lumbar fusions, you'll decrease the rate of radiographic and symptomatic adjacent segment disease. Now, some people have looked at this before. This is a nice diagram from this paper here back in 2004, where they looked at this and they used a couple rudimentary radiographic parameters. They did show that if you preserve the ligamentous tension band, it was only 6.5% of what they called instability, and that was just a radiographic cutoff versus 24% if you didn't. And then there's several biomechanical studies. This one's in a pig model on the right, showing that it does in fact give you more stability, particularly in flexion, as having that tension band there. So I thought I'd look at this a little deeper with our patients, as we pretty frequently will spare the midline and preserve that ligament in our constructs. So the study design, so the cohort of patients we're looking at is anybody over 18 who underwent an open midline posterior lumbar fusion for degenerative pathology. And I'm looking at 2015, 2016, just to get as long as follow-up as we can, excluding infection tumor, just to keep things in the degenerative category. Revision cases are allowed if there's a new UIV involved. So far, we have over 200 patients that we're going through, and I'm dividing the patients into 3 groups. The first group here is I, and this is a representative picture of one of our patients from the study in the group I. You can see that this patient is fused from L4 to S1, and you can see that L4, the complete spinous process, is here. And so this is inferring that the ligamentous complex, including the supraspinous and interspinous ligaments between these 2 spinous processes are present. Therefore, that tether is present between your fused and your unfused segment. This top right photo, D, is a representative picture of this group where that ligament is disrupted. And you can see the spinous process of the UIV in this patient that was fused L4 to L5 for a small spondy. This spinous process was bitten down. And so this ligament is no longer there, tethering the fused to the unfused segment. And this third group, M, is what I'm calling midline sparing laminotomies at the UIV +1. And what this means, this is something that we frequently do here, is where we leave the posterior ligamentous complex intact, but we do laminotomies on either side and decompress both centrally and the lateral recesses, as well as the foramen at that level. And you can see on this AP X-ray, it's probably tough to see, but I'm circling two lucencies, and those represent the laminotomies at the lamina above the fused construct. And so I think this is important because I think surgeons don't necessarily, when they do a TLIF, don't necessarily mind this junction. They frequently will bite the whole spinous process off of the UIV, like you see here in D. And it doesn't really accomplish much because you're not addressing the stenosis at the disc space above by doing that, and you could potentially be destabilizing that adjacent segment. And so I think if this bears out, it could have some impact on how we perform one of our most routine surgeries. And so the outcomes that I'm looking at primarily is going to be reoperation rate, particularly extension of fusion at the cranial adjacent segment. And so hopefully there will be some meaningful difference between groups I, D, and M in terms of reoperation rate and extending the fusion cranially. I'm also going to look at some radiographic parameters to see if radiographically these levels appear more unstable between the groups. And those are the parameters that I'll be looking at. And hopefully I'll have at least 2-year follow-up for these patients, and we can get some meaningful data. So thank you.
Very good. Thank you, Paul. And congratulations on selecting this topic. All of our fellows select their own topics and pursue them. I want to introduce you to Dr. Joe DeTore. Can we switch to Dr. DeTore? He's a PhD and serves as our head methods coordinator. Dr. DeTore, good morning. My question to you is a methodological one. So this is a single system, single center retrospective review. It's a pretty large number of cases. As a methodologist and somebody who's written major review articles and helps us also with the Global Spine Journal Science and Spine section, when you see multi versus single center retrospective reviews, where do you see the pros and cons of both approaches? We can't hear you, Joe. Okay. Good morning, Joe. This is Dr. Joe DeTore. He's a PhD, and we have to unmute him. And he's still muted.
Yeah, there we go. There we go. Can you hear me now?
Yes, loud and clear, and we can see you well.
Yeah.
Good morning.
Well, good morning. Thanks for having me.
Reviews, pros and cons.
Yeah, thanks for having me. The big issue that people need to remember when they do these kinds of reviews is the proportion of people that are going to have the outcome. That'll drive the sample size, whether it's a single center study or whether it's a multi-center study. And so, how often in general does somebody have to undergo a reoperation? That's what you need to consider. If it occurs, 2% of the population, for example, your sample size is going to need to be quite large. On the other hand, if it occurs more frequently, then you're going to be okay. And so that would be the biggest issue. And then, of course, if you have the pros of doing it in a single center study is that you control for the number, you limit the number of surgeons because there's a confounding effect on the person doing the operation and the people around the surgeon who's taking care of the patient. So that's the advantage for a single center study. The advantage for a multi-center study is, of course, you have a greater variety of patients, and so you can apply the results to a wider population. So in short, those are sort of the biggest pros for each.
So this is a very important point. So how often does something happen? Paul, take up this thought. In your best estimate and review of the literature in preparation for formulating the study, how often does a patient with a spine fusion need to undergo a revision surgery over a 5-year course? What's your best guesstimate from the literature?
I would say probably 25 to 30% in the general population. Of course, some percentage of those patients go elsewhere for their surgery. So we lose maybe 10% of those people. So I'm seeing probably about 15% in our cohort.
So this is exactly what Dr. Dettori was mentioning. So this is not an infrequent occurrence. Roughly about, the sport trial said easily 22%, as I remember, over after the 5-year mark, required some form of a revision. And again, it's been hotly debated whether it's or whether adjacent segment wear and tear is an expected or an iatrogenic problem. Sometimes it can clearly be iatrogenic. So in your gestalt, and mechanically speaking, if you preserve the adjacent segment, how much mechanical gain, how much improved stability do you have by preserving the PLC, the posterior ligamentous complex?
I think there's a good amount. I think particularly in flexion, and that's what our biomechanical studies show, and that makes sense intuitively. When you bend forward, that ligamentous complex in the back prevents you from overbending and will reduce the stress on the disc space. There's a lot of things in the back, the supraspinous, infraspinous, the ligamentum flavum. Like in D, the ligamentum flavum is still preserved, but I think the crucial thing is the supraspinous and interspinous ligament. And so I think over time, that does provide some statistically meaningful difference in the rate of adjacent segment disease in patients.
When I asked my partner and on the spine service, the director of our spine service, Dr. Oskuyan, so obviously the option M, the midline sparing laminotomies are a little bit more difficult surgery. In your own practice, do you try to preserve the midline, or do you, because it's so much easier, just kind of take everything off, listed as option I by Dr. McBride?
Yeah, I mean, we try to spare, obviously each case is a little different, but I definitely agree with Paul. I think this is an underappreciated, underestimated problem, and I think it can set you up for different problems down the road. So we try to preserve the adjacent level, but it hasn't really been looked at. So I think this is a great project, Paul.
So Ben, Paul, final question. We see Ben Schell here on the screen. So your listing of patients that had the surgery in 2015, that was done with the design that you'll have more long-term follow-up, is that right?
Right. With the ability to extend further through the years if needed, if we need more patients, if that percentage ends up being too small to provide a meaningful.
Yeah, Dr. Dettori's statement of always looking at the incidence of how often something occurs so you don't end up with microscopic numbers that are very arbitrary and spurious and likely subject to confounding things. So theoretically, you'll be in that 22% window that the sport trial identified following fusions. Good. Great job. We'll switch to our next lecturer, and thank you very much. And please stay around if you can, because we have a surprise visitor for you later also. So seamless transition. Next is Dr. Zach Carterin, and he is going to talk about a subject that the prize guest number 1 was involved with also, Dr. Ben Schell, and we'll ask Dr. Ben Schell to comment on that later. Dr. Ben Schell is a former fellow of ours, and he is now practicing in South Carolina in Charleston, and the location is the South Carolina Sports Medicine Orthopedic Center in Charleston, South Carolina. So Zach, take us forward with this project that you inherited from Dr. Schell. You have your own projects also, but this was such a meritorious project that we really wanted to bring this to conclusion. So good morning, Zach, and good morning in the East Coast, and thank you for joining us in your busy day, Dr. Schell.
Good morning, everyone. This is a wonderful project I inherited from Dr. Benjamin Schell. And it's a project I kind of grew to believe in because I'll show you a number of pictures like this on the right side of multi-rod constructs, but implementation of these multi-rod constructs have become increasingly popular over the past couple of decades, and there's really no consistent nomenclature for discussing multiple rod spinal fusion constructs, especially in between healthcare providers like spine surgeons trying to relate in as few words as possible what exactly is going on with the patient. And so a system of nomenclature would definitely benefit discussions amongst colleagues, would help in research, and ultimately probably lead to more standardized treatment options. So the goal of the project that I inherited was to develop a multiple rod classification system with universal nomenclature. So ultimately what was done was an international multidisciplinary group of 14 experts from United States, Israel, and Germany. And thought leaders were compiled a list of techniques, definitions, names from the literature were reviewed, and the expertise of the experts was utilized, and the list of criteria for the proposed nomenclature system was completed through a modified Delphi process. And 4 key questions were attempted to be answered. 1, how many rods were utilized? 2, how far rostral does the construct extend? 3, what is the purpose of the working rod, which is typically the rod that is placed lower and bears most of the load, the shorter rod of the 2 on one side. And 3, how much, if any, pelvic fixation was utilized. And so this is the trendy name for the scoring system that was developed, the Chrome score, classification of heterogeneous rods for multiple etiologies. And this is a picture of Chrome, the score in a nutshell. So it's a 4-digit score. First number being number of rods used, second number being the rostral most fusion spanning rod. So how high does the construct go? And it's broken down into the categories 1 through 4. Third is a letter, which is the reason for the working rod, and we broke it down into 5, which was deformity, pseudoarthrosis, infection/tumor, neuropathic, and trauma. And the last one is simply a plus or a minus. Pelvic fixation, if there is greater than 2 screws in the pelvis, they get a plus. If there's under that, they do not get a plus or a minus. So what we ultimately did is we have a research meeting here every Monday morning at SSF, and we used the expertise of 6 spine fellows and 3 spine attendings, and we gave them a quiz of the pictures that I've shown. These are all pictures from the quiz on the right here. So I would put this slide up for a minute, and everyone would just look at the picture, and after a brief tutorial on the Chrome score, they would score the picture. And then 4 weeks later, we repeated the same exact quiz with the same fellows and the same attendings. We found an excellent inter-rater kappa coefficient of 0.71, and intra-rater reliability was 0.68, which is classified as good reliability. And we are just completing the manuscript as we speak and getting it ready for submission. If I have 30 seconds each, I can talk about other projects that I'm working on, or we can just discuss.
Let's do this right now. So thank you for taking this project over. This is one of the plights of a very busy place like ours, and that is to kind of complete projects in time in the academic year. And Dr. Schell really took it upon himself with a lot of energy to take this over. But before I go to Dr. Schell, Dr. DeTore, Joe, what is ideally a Delphi process? I see this a lot in the literature, and in very brief sentences, how does an ideal Delphi process look and work?
Well, I would say that for clinicians, for surgeons, spine surgeons, I would say sort of a modified Delphi process is sort of the ideal situation. And basically, the Delphi process is not an end of itself. It's a sort of an intermittent step, which tends to help narrow down a topic with input from the experts. And then once a topic is narrowed down, in this case, it needs to have, I mean, there are probably a dozen different ways one can come up with a classification system. And you can look at all kinds of different things, but there's probably real important components that need to be included, and it's the clinical experts that need to provide that input as opposed to just picking out random variables and stick them into a computer model or a mathematical model and have the model determine what those are. And so the ideal is for clinical experts to come up with the variables that can then be looked at more closely through statistical analysis. But let me say this, that the Delphi process initially was designed to be done so that people who have big personalities don't over influence other people. And so in reality, that can be done a number of ways. One of the ways is that you vote sort of secretly what your opinion is about various things, and it's up to the moderator to keep the person who has the most strong opinion from dominating the conversation, so everybody's input is heard equally.
That's some very valuable insight. So I'll switch over to Dr. Ben Schell. Again, Dr. Ben Schell is here from South Carolina, and he was a past fellow. We asked him, and I see Dr. Ryan Goodmanson, who's also in the same shoes, a past fellow. Morning, Ryan. We'll introduce you separately later as mystery guest number, I think, 3. But thank you for joining us in your busy practice as well. Dr. Ben Schell, so when you took on this project, why did you want to take this on, and how did you modify this Delphi process to make it as above board as possible, and take away the influence of big speakers like Dr. Oskuyan, not myself, but Dr. Oskuyan?
Sure. Yeah, great question. Again, thanks for having me. I really appreciate it. It's good to see you guys. I'll be virtually. But yeah, to answer, it was just something that kind of became apparent as we were seeing so many outside consults that had multi-rod constructs that look like little piece here, little piece there, little, something here to tie off to, to something else. And it just got really frustrating for us when we were trying to revise these, and I would try to either tell Dr. Chapman or Dr. O, and, my co-fellows, even Ryan, like, oh, this lady's got this, and this, but you're not going to understand it till you look at these x-rays. So that's kind of what the impetus was that ignited the fire. And, to make the Delphi process as, I guess, universally accepted as we could, I originally attempted to get as many people involved as possible. We started with a big picture, trying to recruit people at the courses up at SSF, and, trying to get people to do it online from various parts of the world. And, as with all things, during COVID, things got kind of hectic and turned upside down, and the response wasn't what we wanted it to be. So, I'm super thankful to Zach to kind of pick up the reins and push this thing through to the end, and really cement it to be something quality and worth publishing. So kudos to him for sure.
To Zach and you, so in the literature, has anybody tried to formally classify these rods, and how did you come up with the rod nomenclature in terms of what these rods actually do, or how do you call those various rods that are put in there?
Sure. There's various papers in the literature discussing techniques of multiple rod implementation, such as kickstand rods, outrigger rods, satellite rods, but no real paper that comes in and tries to bring them all together and come up with a universal nomenclature system, which is kind of why I grew to strongly believe in the paper. So there was nothing like that in the literature.
And Ben, how did you put these words into, how did you find the words to describe these rods? How do you do that?
That was kind of what the original Delphi process was. I started bugging you guys, and we at our weekly research meetings, we would pass around papers and what words do people think of? What words you're using now? What word makes sense to your brain? And, we slowly whittled it down, from 10 words to 5 words to 3 words, and had people kept voting, and people kept talking about, okay, this is the rod that's doing the bulk of the work. That makes sense. Let's call that the working rod. This is the rod that's spanning the construct. Let's call that the spanning rod. We wanted to make it as intuitive as we could. And that's kind of where those words originated from. Cause like Zach said, there are a plethora of them in the literature, and, to some people, an outrigger rod is this, to some people it's a kickstand rod, to some people it's, just the long rod. So it's definitely was a work in progress, but I think the words that we landed on really describe it well.
So I think you really did a great job, and I'm very grateful that Zach picked up this project. Very briefly, Joe, before I'll ask Ben to give us a little 5-minute view a year later. A kappa value of 0.7, if you go back to that slide, Zach, is that a good thing, or 0.71? Is that a good thing? Is that a mediocre thing? What's a good kappa value, and what's a good intra-rater reliability?
Yes, so the kappa value of 0.7, there are different correlation coefficients that tend to measure agreement and taking into account chance. That's kappa, and so anything above 0.6 is good, and so 0.71 is good, very good, and I'd be particularly happy with that. End result. I think as we were going along, I can't remember, Ben, but initially when we first started this project, the initial number was a little bit lower than that. So I'm glad to see that it's up to 0.7 now.
Great. Thank you. So we'll switch over back to Charleston. Dr. Schell, congratulations on your first year. A year ago, you were standing here giving a view of your project, and here it's hopefully coming to a close soon, Zach. So give us your words of what were your biggest surprises that you encountered in practice? What is the word of wisdom that you want to impart on our fellows?
I think I have two, if I can hopefully squeeze them both in. So I think the biggest thing that I really, discovered was you as a fellow, you are, you're in the trenches, you're taking care of patients, you're in clinic all the time, your volume is high, you're doing a lot of cases, you're doing every type of case every week, and you don't think twice about it. And then, you come out as a new attending, and I went into private practice. So there, it wasn't like people waiting on me to show up, with cases ready. So it takes a little while to build that, and you don't notice it at first, but suddenly it's been 3 weeks since you've done an anterior neck, or it's been 2 or 3 weeks since you've done a TLIF, and you notice that certain moves aren't as intuitive as they were before. So you got to kind of have to do some things on the side to keep your skills up. You go to courses, you do cadaver labs in your cities, you try out new instrumentation with young companies that are always wanting people to test out their stuff. So it's definitely something that I didn't anticipate. You don't notice it at first. You don't think about it, that, not having, done a complex neck, in a month, the certain little things aren't as fast as they were. And then my other big thing that, I really appreciated at the time, when Dr. Chapman would always tell me, but kind of coming into a different state, different coast, basically. They had done spine at my hospital, but, they hadn't done it the way that I do it. And every little thing matters. Dr. Chapman used to always tell us that every little thing matters. And when it's your name on the chart and you're the one responsible for that patient, you're the one seeing them in clinic all the time, every little thing matters, from positioning of the arm boards, to prevent a post-op neurapraxia, from, positioning of the eyeballs on the, on the soft padded pillow, or in the tongs. It's not just anesthesia's problem. It's not just a nursing problem. Every little thing matters, and it should matter to you. And that's one of the amazing things about spine. That's one of the difficult things about spine. That's why, not everybody can do it. And, these are the things we learned at Swedish, and you just have to take a little bit more time, because, you had Swedish, you had an attending and a fellow doing all those things, or you had 2 fellows and the attending coming in, or you had a lot of hands and a lot of people and a lot of experienced people. And that's not always the case in every hospital you go to. So you've got to make sure that you have your checklist either in your mind or before the case, and you've kept it for the year at Swedish, and you're kind of writing the little things down. Okay, got to make sure to do this, got to make sure to do that. And then these are the 10 other things that before we scrub, I got to make sure all these things are in line. So those are the big things for me, is that be cognizant of the volume for sure, because it will change. You're not going to come out to 10, 12 cases a week, and be cognizant that every little thing matters, because it does.
Awesome. Thank you so much, and thank you for joining us, and please feel free to stick around in our panelist room and comment on anything else you see. We'll stay totally on time, and thank you all for staying so much on time. Dr. Puri Hayumi joined us from USC in LA, and we have a mystery guest joining us. Good morning, Dr. Jeff Wong. He's the Vice Chair of Orthopedic Surgery at USC and the Chief of the Spine Service. And he served as a mentor and I think inspiration for Dr. Hayumi to go into spine. We've been very privileged to have Puri here, and he's going to talk about a research presentation of his, a project that he's done over the last year, and we'll ask Dr. Wong to critique it.
Sounds good.
All right, Puri, good morning.
Thank you, Dr. Chapman. Good morning, Dr. Wong. So I'll be presenting my research study that I've been doing for the past year or so. The title is Relationship of Cervical Imaging Parameters as Predictors of Construct Failure and Posterior Long Cervical Fusion. As background, posterior cervical fusion is being used increasingly. There was almost a threefold increase from 2001 to 2013 in the United States, and this has been attributed to the aging population, greater number of fellowship-trained spine surgeons. However, there are much fewer studies published on posterior cervical fusions compared to the anterior approach, and even fewer studies have reported on long construct posterior spinal fusions. So the aim of our study, this is a retrospective clinical study. The aim was to correlate a preoperative radiographic imaging, including sagittal measurements of the cervical spine and clinical comorbidities and CT-based bone density as measured with using Hounsfield units to measure outcomes, including hardware failures, non-unions, and reoperations. In terms of the cervical parameters that we use, there's been a large number of sagittal parameters defined and studied, not as extensively as lumbar parameters, but these include cervical lordosis, cervical SVA, T1 slope, thoracic inlet angles, and neck tilt. Out of all these, neck tilt is, T1 slope probably has been studied most extensively, including Dr. Wong that has studied that using kinematic MRIs. So we use that as kind of the parameter, the main parameter that we use in addition to cervical SVA and lordosis. And we use also coronal Cobb angle in our measurements as well. So the methods that we use all patients that had any long segment posterior fusion, and we defined that as anything that includes upper cervical from C2 to at least upper thoracic T1 between 2015 and 2018 that was done at our facility. The radiographic measurements, as we discussed, was cervical lordosis, SVA, T1 slope, and coronal Cobb angle, immediately pre-op, post-op, and at least 6 months follow-up. And as I showed in that picture, we measure our Hounsfield unit using an ROI angle on a T1, mid-T1 vertebral body, excluding cortical bone. The results and the outcomes that we were looking at, as I mentioned, we were looking at hardware failures, non-unions, reoperations, and et cetera. Preliminary results so far, we haven't done the final statistical analysis. So we ended up having 79 patients that met our inclusion criteria and had the minimum follow-up that we needed. The number of revision surgeries total were 13, and this includes everything, including hardware failure, infection, seroma, so all comers basically. Revisions just for infection / seroma, there were 4 patients, and for hardware failure, there were 6 of them. And interestingly, most of them, majority of them were caudal end failures. The average T1 slope, post-op T1 slope was 38, and for an average T1 slope in patients with caudal end failure, I expected it to be larger, given that the amount of shearing force that would be on the T1 vertebral body, but it was 41. Interestingly, for our Hounsfield unit, average T1 Hounsfield unit for all our patients was 235, but only including the 5 patients that had caudal end failure, the T1 Hounsfield unit was significantly lower, and it was 194. The weakness of the study, it's a retrospective study, and our follow-up is only 6 months to be able to have a large number of patients included in the study. No PROs are included, unfortunately, and the other big thing is that the discrepancy in measurement between upright x-rays and CT, wherever we had available, we use upright x-rays, but as you can see, this is the same patient. Both of them are post-op imaging, and the measurement of SVA and lordosis, there is a difference between the two, between CT and upright x-ray. And in some patients, actually, the discrepancy can be even larger. So that's something that we definitely have to address in the final paper. Thank you.
So thanks for this very concise overview. Can you go back to that last picture. Was the postoperative immobilization categorized? Have you caught that? Is there a difference of using a regular hard collar or some form of cervical thoracic orthosis?
That's not something that we looked at specifically in this study.
And in your, so that's one other thing to add to the weaknesses, but I think it's a very meritorious study. And again, it's very humbling to see reoperation rates. How well or how much do we know about the ROI, the region of interest calculations, which have been well established now as a screening tool for the thoracolumbar spine lower down? How consistently has that been actually evaluated and kind of crossed over into the upper thoracic spine?
So not as much. I've found maybe 3 studies that looked at it, and definitely not in the setting that we're looking at. One of them was to look at subsidence rate after ACDFs, and the way that they measure it, and there's no kind of standard measurement of cervical ROI as well. Each study kind of had a different way of measuring it, either using sagittal, using averages on the axial view. So that's something that we have to address. The way we do it is basically the way it's done in the lumbar spine, is looking on the axial view, kind of mid-body. But again, there's definitely not as well studied in the cervical spine, and no definite standard way of measuring it.
Great. So good morning, Dr. Wong. Thank you so much for joining us. Jeff, it's a real privilege to have you. Are you unmuted?
Yeah. Hey, thanks for having me. I don't know what you guys did to Poria. When he left USC, he had a full head of hair. I'm not sure what you guys did to him during the last year, though.
It's transformed. His hair has transformed to the lower half of his head.
Yeah, moved down. Good morning, Dr. Wong.
Good morning, Poria. Listen, great study. This is a very practical study. It's obviously a problem that would affect all of us when we're doing these long constructs down into the thoracic spine. And if we could find some way to predict which ones are going to fail, which ones we need to go down lower past T1, I think that would be of huge benefit to the spine world. I guess my questions to you is when you say hardware failure, how did these fail? I know you didn't have a ton of failures, and so I think you talked about the fact that you don't have a lot of patients in that group. But how did they fail? Did they pull out? Did they sort of fracture at that distal junction?
Majority of them were fractures at the LIV or LIV, well, I guess -1. So kind of a burst fracture either through the screws at T1 or T2 or the right level below.
Okay, and I imagine you looked at everything, and so the only thing you found was that the T1 slope was just a little bit higher in the ones that fail?
Yeah, I was hoping that we would find something, obviously bone density was significantly lower in that group, but the T1 slope I expected to be much higher in the group that failed, but it doesn't seem to be that much of a difference, at least based on very preliminary analysis.
Okay, and did they all go down to T1 and they fail, or did it make a difference whether you stopped at T1 or T2, or they were just kind of doomed to fail?
I think majority of them actually ended up at T2. I think that seems to be the standard here, that we end at T2 or lower.
Yeah.
We use the T1 slope because that's the parameter that's been defined for the cervical spine.
Sure. Well, you know, the interesting thing about some of these studies is that, when I heard you present it, you were like, well, we found the T1 slope, you expected it to be a little higher. But I think a lot of these studies, sometimes finding negative data is very valuable, because I would have suspected that, you know, if they had more regional imbalance and they were really off, that it'd be more likely to fail. And if you find that that didn't affect it, that's huge, right?
Yeah.
Or if you find all these other parameters you looked at and you found that those were not associated with distal failure, I think that's important information that needs to be out there.
Right.
So I commend you for this study. I commend your mentors for coming up with the ideas and helping you through this. And I would encourage you to continue this through to publication, because this is very practical information. And just because you don't find a lot of positive data associated with it, kind of tells us, it makes us feel good as surgeons, because if we see it, we say, hi, we couldn't have predicted it. But at the same time, having all that negative data out there showing it was not associated with all these other parameters maybe helps us guide us a little bit more and maybe feel a little bit better about our patients.
Thank you, Dr.
So thanks for joining us, Jeff. Quickly, for 2 or 3 minutes, give us your clinical paradigm in cervical thoracic fixations. When should we stop at 1, 2 versus lower? Are there some tips and tricks? And I'll give you a compound question. do you use the ROI calculations in the upper thoracic spine to try to guide us? Is that a valid measurement? Is that at this point just too raw?
Yeah, I don't really use that measurement. And Yen, sometimes you just look at these and you just get a sense, hey, this one, I need to go further. This one's, it's going to fail. I guess for me, I look a lot at the angle between C7 and T1. Because in some of the data we looked at is that a lot of the people that had the most imbalance, they had either a neutral or they were a little kyphotic there at C7, T1. And that angle really, if it's neutral or kyphotic, then I try a little harder. I may go a little bit more distal. I don't want to approach sort of the thoracic kyphosis, but I tend to go a little bit lower on those. A lot of times, if that angle isn't so bad, I'll stop at T1. I tended to think, obviously, if there was a lot of regional imbalance and they were really imbalanced and I was really working hard to get them back, that I would go a little bit lower. So I actually thought that you were going to find that if they were off and the regional imbalance was worse and the C2 to C7 plumb line was way off, that you would find more failures. And so I'm kind of happy that you're not seeing that association. Certainly doesn't mean it's not there. I would encourage you guys to get more numbers on that, but again, very practical information.
Well, thank you so much for joining us. And Purya, hopefully you'll conclude this rapidly so you don't have to pass this off because as you heard from Dr. Wong, this is a very meritorious subject. Jeff, one more question to you is any words of wisdom for our fellows from somebody who's been at the pinnacle of our profession and one of our major leaders?
I guess my advice is you never stop learning. I think you guys know that. You obviously had great mentors during this year, but never stop learning, never keep your mind closed. I think when you go out there and you see people that are very successful and the ones that maybe haven't achieved what they wanted to achieve, I think the people that are most successful have a little bit more of an open mind. Even at my age, I'm getting old, I still try to keep an open mind and try to learn new things. And I don't get too set in my ways because I think life is a learning experience.
That's a wonderful thing in spine. And again, everything counts, as Dr. Schell said, and it never ceases to amaze me what we learn. And we appreciate the hard work of our fellows and the insights that you gain and the sometimes difficult mirror that we're confronted with when we critically look at our results. Always strive to get better. Jeff, thank you so much for joining us. It's a huge privilege and great joy for all of us to have you. And it was great to have Dr. Hayumi here and this connection to USC. So we did rib him a little bit about the LA background. So, but that's for a different forum to discuss further.
All right. Well, thanks for having me. Take care, guys.
See you. Take care.
Thank you,
Bye-bye.
Dr. Wong. Thank you.
See you, Purya.
All right. Next, we have a fellow from Germany. So we're staying international from LA to Germany, to Bochum. Dr. Perry Gadulius is going to talk about his basic sciences research, and he's had a couple of interesting projects. We had to limit it to one. So good morning, Perry.
Hi, thanks for having me. Okay, so thanks for the introduction, Dr. Chapman. Perry Gadulius is my name. I'm an orthopedic surgeon and trauma surgeon from Germany, from University Clinic of Bochum. And I'm in a row of my predecessors who spent here the last 5 years. So we're in the 6th year of our German fellowship as SSF now. And after coming here, I got into the lateral spine surgery, really interested with that. And I have to take a little excursus before I present my cadaveric study that I was doing on the branches that actually innervate the psoas muscle. Because coming here, I was first time actually experiencing lateral spine surgery. And when you go through the different trajectories, you see that, of course, you can go anterior to the psoas muscle or you can go trans-psoas muscle. And you start wondering what are the complications of these things. So I actually first started with some chart review studies on the complication rates of standalone patients. We almost had 160 patients in this group. And we found out that basically the most common complication that we found was the temporary hip flexor weakness. Then I did the same thing for patients who had a lateral approach followed by an ALIF or a different posterior approach. And here again, because of the posterior instrumentation, you have a little bit higher incidences of bleeding complications, which are not that common in lateral spine surgery. But then again, we had like the temporary hip flexor weakness as the second highest incidence again. And then I got into the literature and I was looking at what have other studies shown about the different anatomical structures and trajectories of the branches of the lumbar plexus through the psoas muscle. And I found out that they were mainly focused actually on how the distribution of the different branches is carried out in the posterior wall, or they were taking MRIs and seeing if they can find different safe paths through the psoas muscle by identifying the different trajectories in these planes. I only found one study which actually really took a look at the branches that came from the lumbar nerve roots and innervated the plexus, the psoas muscle, and they found that there were on average 6.3 branches which come from the anterior nerve root and innervate the psoas muscle, which are at risk on a lateral spine surgery. So we have all these beautiful anatomical illustrations in the books, and this is from an anatomy app which I have on my iPhone actually, which is pretty helpful sometimes, but it never shows you that what is happening to the nerve roots which are inside the muscle. It always just focuses on the main lumbar plexus nerve roots that we all know. So what I wanted to do is I wanted to dissect the plexus muscle, the psoas muscle on two cadavers, and actually see if I can illustrate the nerves that are inside the muscle and not taken care of or not even named, let's say, like this. So I elevated the psoas muscle, and there you can see pretty beautifully how the branches are distributed to form the femoral nerve in the back of it. And after taking away the psoas muscle, really diligently for like a whole week, I was able to expose this kind of almost spider web of nerves which are connected to the sympathetic chain in the front. As you can see, I left the tendon of the psoas muscle there to show that these nerves are even connected into the tendon, and there you can see these nerve branches that are actually coming from the anterior root, and all these things I've set up on the K-wire, they are inside the muscle belly, and they are of course being pressed on by the instruments that we insert there on a lateral trajectory. But what we wanted to do is see if we can take these things out of an MRI from the cadaver that we did the dissection on, and work together with a company who does 3D prints for healthcare purposes in Belfast, Ireland. So we had to mark all the nerves in the axial planes of the MRI to actually be able to differentiate them from the fat tissue. And we got a sketch fab. There we attached the disc levels and the psoas muscle on one side to it. And in the end, we were able to print that, and we got these results. The discussion will mainly be about that 3D printing yet in medical senses is not able to show the little nerve roots which go through the psoas muscle, because we have the limit of 1 millimeter that we can actually print in diameter, and these nerves are mostly smaller in diameter than 1 millimeter. Yeah, that's basically the project I'm working on right now.
So Perry, this is great. I really commend you on taking a conceptual idea, founding it in a clinical background scenario, and then taking it to the next step. What have you gained from your actual computer model, which is now actually an in vivo model? This is the reality. This is not something compared to the computer diagrams that we saw before. If you juxtapose them both, what is different and what do you derive from that as a clinician?
Well, as I said before, we were not able to show the nerves which have a diameter less than 1 millimeter. So it's really hard to take this out of the computer model, because you have to mark each and every nerve in every Excel slide. So to me as a clinician, the 3D printing is yet not precise enough technique to, let's say, get a 3D print for every patient I will do a lateral surgery on.
Dr. Skurian, so you're one of the 3 pioneers of far lateral surgery. What insights have you gained from this, and how would this affect your practice? Do you envision this becoming something that would exclude patients from this kind of a surgery?
So I want to congratulate Perry and Zach, because this has never really been evaluated and looked at. And actually, these little branches are what matter, these interconnections. And this is an amazing dissection that these guys have done. And it just shows you how complex the lumbar plexus is and how underappreciated it really is. And I think it's going to add a tremendous amount to the literature. So I'm so excited. And these 3 papers that they're working on are going to be game changers. So great job.
Just quickly, for our patients, what should we tell them are the expected neurologic sequelae, and what is an expected kind of a byproduct, let's say a neuropraxic 2 to 3 week period versus something that's a significant complication? So we draw the line.
Yeah, so I tell all my patients, they all have 100% have hip flexor, hip extension, abduction weakness. That's temporary. The numbness is almost exclusively, 100% of them get numbness. Usually by 6 weeks, it's better. The neurologic deficit is very low, but when you do have it, it's devastating, because it's like a peripheral nerve injury. You hit multiple muscle groups.
Dr. Vittoria, are you with us? Joe? So one common question, I have a double question again. I always have double questions, it seems. And that is, when we have an anatomic model, how can we correlate that visual that we have here from, let's say, this computer-generated model to an in vivo model, which we see in a cadaveric version? Is there any way to mathematically correlate that so we have kind of an anatomic correlation? When you see anatomic studies, we usually have single-digit cadaver numbers simply for practical reasons. What's a meaningful anatomic denominator to have?
I really don't have an answer for that question, because my area of expertise is really in clinical. I would say this, that's often the next step, right? Is after you have the anatomical, there has to be some kind of clinical correlation. So I wish I could give you a better answer, Jens, but I don't know with respect to numbers on anatomy.
That's fair. This is a common problem for us. So Perry, where do the sympathetics run in that diagram? Where would we expect? And did you see sympathetics, or was that just below resolution at this point in time?
In the dissection, I have them, but in the diagram, we don't have them.
Can you show with the cursor, using the cursor, where they would run on the spinal column?
Like on the dissection, they are running here in the front.
In the front, yeah, so anterolateral. Yeah. So the oblique inner body fusion would hit those areas theoretically, right? Did you find in your complications review sympathectomy results? Was that a factor in some of the postoperative complications that you saw?
So other authors have mentioned this complication. We, in our chart review, we haven't found any of these.
Great, okay. Well, we'll stay on time, and we'll switch our next lecturer. Thank you so much, Ravi.
Thank you.
Sorry, thank you so much, Perry. And we have Ravi coming on.
Yes.
And maybe with a camera, Lee, can you use panouts to see Lindsay, our fellowship coordinator? Can you take the overhead robot camera back there whilst Ravi gets connected? I want to recognize our fellowship coordinator. This is Lindsay. Thanks for all you do. And we have Dr. Abdul Jabbar here. Amir, new father. Thank you for joining us. And we have Sue Thomas behind Amir. Can you wave? She was the previous fellowship coordinator. So thank you for all you do, guys. And we'll have Ravi go next. And he's talking about a all too common, self-chosen, so it seems, a vice and problem, and that is nicotine and spine.
Yep,
And
thank you, Dr. Chapman.
we have no picture right now, so let's see what's going on with that. I hope it's not some ransomware attack.
I hope not.
Is it your laptop's incompatibility?
I don't think
So Dr. Ravi Nuna came here from Chicago. It's a loose connector.
Oh,
Here we are.
There we go. So thank you, Dr. Chapman, for that kind introduction. So this year, I decided to do a project on the risk of non-union in smokers. And we did...
Lee. Your laptop.
Yeah, it must be my laptop.
So why don't you extemporize and talk for a second?
Okay, so we did a meta-analysis on the risk of non-union in smokers. And overall, for our study, we sought to amalgamate as many of the articles were out there. The reason for our study was that obviously nicotine is one of the biggest issues in spine surgery today. As a public health issue in the United States alone, cigarette smoking is associated is the leading cause of death and preventable disease and disability and death. It's been estimated that smokers comprise nearly 24% to 32% of surgical spine patients. And obviously, as we've all seen in our practice, smokers have some of the highest risks.
Robbie, excuse me, we have a feed problem with your laptop, it seems. So we are.
That is the other one.
Oh, that is it. Maybe this is my laptop.
Are we live again? Okay. All right.
So this is a Pico table that we. No, it's
Might have to.
Yeah, maybe should we just put it on chat email too?
Yeah, sorry about that. I didn't realize it was.
Oh, my bad.
This is very pertinent to your laptop, right?
I think it's me. It's my fault.
So why don't we take this quick switch? Dr. Goodmanson, Ryan Goodmanson, are you there?
Yes, sir. Can you hear me?
Yeah, we can hear you loud and clear, and we'll put you on next.
Yeah, sounds great. Thanks for having me.
Fellow with us last year. He's been one of the rock stars from our last year. And he's joining us from McLaren, Port Huron Orthopedic Surgery. He's a spine surgeon there and has been an immediate success story there from what I gather. Share with us over the next 5 minutes what you've kind of seen as your biggest surprise as you've entered practice by yourself.
Yeah. Well, thanks again for having me. I would say I would have to echo a lot of the things that Dr. Schell said at first, but I picked out two things, and one is patience and limitations would be my two things to take away. That's piggybacking off of his stuff. You know, I'm coming to a facility that just didn't do a whole lot of spine, and they really didn't do any complex spine. And when you come in guns blazing, it's hard for them to adapt to that. And so it's been learning to be very patient with them, learning to help them understand the details, because we were taught the details very well. And I would echo that the devil is in the details, and you definitely have to pay attention to all that, but they maybe haven't had that experience. And so to come in and to be that leader that they need, be that person that they look to, and to instill that in them, what was instilled in me, has been challenging, but a good. It's been fun in some ways, and it's been pain. Just learning to be very patient with everybody, and know that everybody is learning alongside me at the same time, has been good. The other thing has been limitations. Again, the guns blazing. I want to come out and I want to do a T10 to pelvis on somebody, or I want to come out and do a big surgery, or I want to even do a C1-2 fusion or something like that. And I have to know the limitations of my hospital. I work out of two different hospitals, and one hospital has, my main hospital does not have things like neuro IR or neuro CV backup. And so God forbid I get into trouble, I need to have that backup and know what I have at my hospital. And so alongside that is creating relationships. I've noted that creating relationships with people like neuro CV, neuro IR and those types of people. Even ENT has come into play as of recently with a fairly complex case that I have, which is a ossification of anterior longitudinal and posterior longitudinal ligaments in this patient. So essentially a pretty robust dish has come into play. And so really exploiting those relationships, forming those relationships. And since it's the Midwest and everyone up here is extremely nice, it has been fairly easy to do. But at the same time, you're getting people out of their comfort zones a little bit. And so you have to not only push them, but do it in a safe way. And so creating those relationships with people has been another thing that's been fairly critical, I think, to the success that I've had so far and hopefully continue to have.
Those are very valuable insights. So being cognizant of the environment and trying to build up practices. Have you had a lot of team meetings? Have you kind of been able to gel a spine team together composed of nursing, anesthesiology, PT, et cetera?
Yeah, so we've been working on that. That has been very challenging. They did not have any interventionalists up here when I first started. And so we actually brought in some interventionalists to help us with our preoperative and our workup, our conservative treatment. So they've been integral to that. Working with our anesthesia, so taking things from Swedish that, using the relationships at Swedish to then further that here by giving my anesthesiologists understanding of what we need in complex spine surgeries, what we need in bigger surgeries as far as that goes. And then another team that has been almost invaluable has been the ICU team. And thankfully, they do a lot of cardiac surgeries up here. And so they're used to bigger surgeries when it comes to that. But they have been very willing and very receptive to learn the difference between that and large complex spine surgeries. But it's, again, a team. I wouldn't be able to stress it enough how important a team is. You come out or you're in fellowship and you literally you get spoiled, I think, a little bit. You have extra sets of hands, you have good hands, and that's fun and that's awesome. It's just different. And so getting used to the difference that there is when it comes to you're the one doing all the work, depending on where you go. That's very dependent on, if you're going somewhere with residents or not, or if you're going to private practice, but having that extra set of hands, versus you're the one doing the work now.
One more question. In your first year in practice, have you been busier than in your fellowship? You're very busy. I remember you're pretty unshaven there for weeks out of hand there during residency, and you're pretty well shaven now. So almost well shaven, I'd say. So 1 or 2 year beard. So are you working harder now or not?
I would say it's just different. I would say that we work pretty darn hard in fellowship, but it prepares you for what you have to do. It's just a difference. It's maybe I'm not doing as many cases because I don't have 3 block days a week, which I wish I had, but I'm working on that. But it's just different types of work. The support isn't quite the same. And so I'm doing more of I'm just doing different types of work, basically. Surgery wise, though, it is still very busy. I mean, I take trauma call at the same time. And so I'm doing trauma cases. I did a peel-on last week in a 17-year-old. So there's a lot of different types of things that you have to deal with coming out that you maybe just don't even think of because they're just not on the forefront of your mind. But when you come out, you learn real quick.
One thought I want to pick up on and endorse, and again, it's so cool to see you, and we're so proud to have been involved in the education. Thank you for taking the time to come on. One theme I want to come on, many administrators see spine kind of as a cost center or a service line that's profitable. But beyond that, I really liked, and that theme resonated with me, that a healthy spine line can actually improve the overall functionings of the body, if you so will, of a hospital. Because basically, just like the spine connects the brain to literally all visceral organs and extremities, it also can serve kind of as a backbone to a hospital. If you have a healthy spine service, so many other functions like anesthesiology, interventionalists, as you identified, but also mineral metabolism, pain services can improve from this, PT services, all that can improve if you have a healthy spine service. Would you agree with that?
Oh yeah, it's huge. I can't tell you how many meetings I've had with just everybody, and we've actually tried to put together a spine meeting because they didn't have it. We have a joint and spine excellence meeting now that we've put together where we meet, and it's still a little bit of, not necessarily the beginning, but we're working into it. But we've worked on things like getting PT together to figure out, how do we rehab these patients because they haven't really done it before. When do we do surgery on these patients? Because we always want to do the right surgery on the right patient at the right time. And have they gone through all the treatments up to that? So the pain service line, everything from that to perioperative, and preoperative treatments. Do we need a specific spine preoperative, boarding form or something like that? And it's that kind of stuff. But it's been nice because it is just that, it's a spine excellence meeting. We're meeting, to push that forward so that everyone's on the same page and that we can work together as a team, because it's literally the best way to work. You can't do it by yourself.
Well, thank you. I would not do my job as a Foam Fellowship Director without reminding you that you have a landmark paper that we still need to come to conclusion, post-operative urinary retention. So I'm going to send you an email separately, but I'm looking forward to that finalized product. Right, Dr. Dettori? That urinary retention, that was a big deal, and we'll get that to a conclusion. Okay, Ryan?
That sounds excellent. Thank you. Thank you for having me as well.
So back to nicotine. Thank you, Ryan, for your words of wisdom. Ravi, nicotine and spine, an ongoing problem. Maybe you go back a slide.
Yep.
Great.
So starting again, sorry about that technical disruption. So this year, my project was a meta-analysis on the risk of non-union in smokers. This was a project I did with multiple co-fellows that I had here, as well as Dr. Dettori, who's had a lot of experience with meta-analyses, and it was definitely a great learning experience for me. So we sought to do this project because smoking is such a large public healthcare issue, and also in terms of surgical spine patients, it comprises a huge portion of our patient volume. Our inclusion criteria were adult patients undergoing spinal fusion, either single or multiple levels, cervical or thoracolumbar fusions. And our exposure criteria were people that were smoking 1 year prior to their index surgery. We excluded all other forms of tobacco, such as smokeless tobacco, vaping, hookah, or anything else. We just were looking at cigarette smoking, and we used a pretty restrictive criteria here. We came across dozens of other studies that had different criteria, but we elected to use something that was fairly restrictive, and we looked at patients. We defined smoking as 1 year prior to index surgery. And then we looked at patients out at least at a year. We also graded the strength of evidence of all of these studies. Overall, we ended up screening about 2,000 articles, and that was condensed down to a full text review of 74 articles. And then we ultimately condensed that down to 20 articles that were included for this key question. Overall, between these 20 studies, we amalgamated about 3,000 patients, which included 37% smokers, or about 1,100 smokers. Overall, in the pooled analysis, we found that smoking was associated with an increased risk of non-union compared to non-smoking, with a risk ratio of 1.9. This was also the case whether smokers were having placed allograft or having autograft placed, with a relative risk for allograft of 1.39, a risk ratio of 2.04 for autograft. And then the same also held true for our multi-level and our single-level analysis, with a risk ratio of 2.3 for multi-level, and then 1.8 for single-level. And then just doing a deeper dive on some of our tables here, just pointing out some of the interesting things that I thought were clinically relevant here. When we looked at the time course following smokers and non-smokers, what we actually found was that for non-smokers, their pseudoarthrosis was generally declared after 1 year, and there wasn't much change from 1 year to 2 years. However, for smokers, the rate of non-union, the fusion rate actually improved from 1 year to 2 years. So this showed kind of that smokers actually do take longer for that bone healing process, and sometimes that bone healing process is just completely impaired. And you can see that for cervical cases and thoracolumbar cases, that smokers actually improve their fusion rates between 1 and 2 years, but not necessarily the case for non-smokers. In terms of looking at single and multi-level fusions, Not unsurprisingly, we found that thoracolumbar fusions were associated with far higher rates of non-union for smokers, and you can see a risk ratio of nearly 3 in our thoracolumbar fusion group. In the same table, you can also see here that multi-level procedures were also associated with a significantly higher relative risk of non-union for smokers. And then finally, another interesting aspect was that, and this was actually Dr. Torrey's idea, that to look at autograft and allograft. And for a while, we thought that the findings were pretty curious, that and that autografts seem to be worse in smokers. And we found that both in cervical cases and thoracolumbar cases. Obviously we don't know the exact reason for this, but we could hypothesize that in autograft, the bone itself is so impaired that even using that as a substrate for bone healing most likely doesn't, confer too much benefit. And actually allograft might actually be better in smokers. These are just forest plots of the same analysis that we repeated. We actually did not find a difference between the subgroups in terms of cervical versus thoracolumbar fusions, even though both carried an increased risk of non-union. Same thing for comparing single level and multi-level segments. There was not actually a difference between the subgroups, but there was positive findings in both subgroups. In terms of this analysis, the only difference was actually between allograft and autograft. And actually, we did find a significant difference in terms of the risk ratios here. But again, both groups were also positive in that smoking was significantly associated with a higher risk of non-union, at least at 1 year out and at 2 years out.
So, Joe, first question. Are you live?
Yes, I am.
So explain relative risk to us. Go back a couple of slides, Ravi, if you will. So I thought, first of all, I must disclose, when Ravi proposed this project, I was less than enthused. I said, oh, this is well covered by the literature. And I'm very curious, because you've just submitted this paper for peer review, what the reviewers will say. And then when Ravi showed me the gaps in the literature that I took for granted, I was amazed. There are huge gaps. Right. They're enormous. So explain to us, first of all, what does relative risk mean? Like a relative risk of 2, which I see down there. Does that mean it's double the risk? Or what does that mean when I talk to a patient?
Yeah, so there's two types of risks. One is a relative risk and one is an absolute risk. And so the relative risk is just as the name implies. It's the amount of extra risk, if you will, relative to if you didn't smoke, in terms of a ratio. And so, yes, you're at twice the risk. But what's even more valuable in this paper, because Ravi actually only identified studies that presented absolute numbers of patients who had non-fusion, you're able to calculate what's called a risk difference. And so the absolute risk is important as well as the relative risk. And you can actually calculate what the excess risk is with somebody who smokes. And so, if you tell somebody that they're at twice the risk of non-union, well, the question that I'd have if I was a patient is well, what is that? Is that 1% that goes to 2%, or is that 10% that goes to 20%? And that's the difference between the relative risk and the absolute risk. So in this case, for example, if you look at thoracolumbar 1 level, the relative risk is almost it's a little over 2.5, 2.7, and the excess risk is 20%. So of all the patients who end up with non-union, 20% can be attributed to the smoking. Some's going to happen in people who don't smoke, but there's going to be an excessive risk of 20%. So this Ravi has done a great job on this paper. He's to be commended. There's lots of information here that's not anywhere else in the smoking and spine literature. He's to be commended for this.
So two quick things before we go for our final paper with Dr. Rick Price. First of all, good morning. It's still morning with you, right? Dr. Eric Heyman, Assistant Professor in Neurological Surgery at the University of South Florida, Tampa. Great to see you.
Thank you.
So Ravi and Joe, go forwards to the meta-analysis slide, and then I'll have a question for Dr. Heyman. So first of all, does this paper show the power of meta-analyses? I mean, all of these studies kind of had a bar crossing the midline. They were not that scientifically significant necessarily. But once you pooled the data, it became very clear that there is a effect of smoking, an adverse effect. So Joe, meta-analysis, is that proof? What is a meta-analysis over a systematic review? Maybe just in one or two sentences. And then is this the power of an analysis exemplified here?
Well, the answer to your second question is very easy. You see it right on the screen. Yes, the big advantage to pulling the data, of course, is that you increase the sample size. A meta-analysis is a subset of a systematic review. A meta-analysis is done in the context. It's the quantitative analysis of a systematic review. Not every study has enough articles that you can actually do a meta-analysis on within a systematic review. And I think one of the papers that the fellows did on THC is an example of that. We didn't have enough studies to do a meta-analysis, yet it's still a systematic review. And a systematic review is much bigger than a systematic search. It's you can ask Ravi about it. It's about a 12-step process that can be quite laborious. But so that's the short answer to your questions. Yes.
Ravi, I have a great chat room question from Dr. Venkatesh Krishnan, and he brought up something I had not thought of. Could it be that there's more allograft used than autograft in these patients? And do we know the smoking history of allograft donors? The latter, I obviously assume, is we don't know. But what are your thoughts as you hear this question? I thought it's a clever question.
What do you mean by, I guess, what do you mean by more
basically
numbers?
You have way more allograft available. So let's say in a posterior thoracic lumbar fusion, you can open up another 10 cc's of allograft and put in more theoretical donor mass rather than from the more limited iliac crest. So volume of graft, could that be a confounding factor?
Definitely. I think that's a great point. It's a very insightful question. I guess my only question for that would be, when we are not looking at smoking as a confounding factor, generally autograft is the gold standard. Even in studies that compare autograft to allograft, generally autograft is found superior substrate for bone healing. So that's why I think the results of this are so curious, in that we found the reverse to be true. And another great point, in terms of the history of the cadaveric, the bone donor, and that they could definitely be smokers, especially if they were recently deceased and the smoking rates were higher several decades ago.
Yeah, I want to thank Dr. Krishnan for this very good question. I'll have to put that in the manuscript and credit him for that.
Yeah.
Eric, our professional societies always insinuate that it's okay if we tell our patients who are active smokers to stop smoking at 0.0 before they go to surgery. This study has a way more stringent criteria, right? 1 year.
1 year.
So within 1 year, you're a smoker, yes or no. It's very binary. What are your thoughts after seeing this? Should we have a far more stringent kind of a selection criterion on patients when we schedule them for a elective spine fusion surgery? You're muted, Eric. Sorry, we can't hear you.
I mean, I think this kind of gets into the, some of the questions that we have, because smoking is a moving target with this country. Tobacco use is not the same problem it was even, 20, 30 years ago. But we are seeing a rise of or so-called smokeless tobacco products, such as vape pens. And so I think the ultimate question that really, I think, remains open is what role this is due to nicotine and nicotine inhibition of bone products versus longer-term accumulation of toxins, TARC-like compounds, which in some studies have been implicated as the primary driver of a lot of tobacco-related pathology. This is actually an issue in my mind because I recently had a patient who, presented to my clinic, and every time I'd seen her, she reeked of tobacco, but she honestly had quit smoking cigarettes. And she didn't realize that vaping was, in fact, a form of nicotine use. And I found out that she was still vaping post-op day one when the nurse took her vape pen away in the hospital room. So I think it's unfortunately at a basic level, we still don't understand why tobacco is bad. And I think, the study helps, certainly makes me consider longer term cessation than just, in the immediate perioperative period. I think without a good mechanistic understanding, it's very hard to determine what the best thing for our patients are.
And we're a little bit pressed for time. Dr. Nuna, briefly, Dr. Sohail from Pakistan asked, what causes non-union? You did an obviously very thorough review, and there's another paper coming out of yours. Why do nicotine-using patients have retarded bone healing? What's the micro mechanism? Is it a microangiopathy?
It's a microangiopathy, exactly. It impairs the vascular supply.
So how does that happen? Is it a lack of proliferation in tissues, or is it poor vessels? What's the problem?
I think it's both. I think it's both poor vascularization as well as poor healing, essentially.
Yeah, from what I gather, it's a lack of proliferation. It's a genetic expression that governs the arborization of early capillaries. And basically, it's cut down by a factor 9 with nicotine use. And what Dr. Heyman says is spot on. It's nicotine that's a problem, as far as we know. It's not inhaling something with tar in it or so. It's the nicotine that causes that genetic suppression. I can't recall the name. Thank you for this very thought-provoking paper and sharing your insights with you. And it's a really solid job. And thank you to Dr. DeTore for all your invaluable insight. Next up, and our last research speaker is Dr. Rick Price, originally from WashU. And he took on another public toxin project, which was novel. I congratulate him on having the idea. It's somewhat controversial. It's cannabis, THC, and pain management. So Rick, good morning.
Hey everybody, I'm Rick Price, as Dr. Chapman said, from WashU. Thanks for the introduction. And I'm going to talk about something that I really thought about coming here to Seattle, where I trained at St. Louis. Cannabis is illegal, and medicinal cannabis was just legalized as I was leaving. But here in Seattle, medicinal and recreational use cannabis is legal, and a lot of our patients partake. This introduction of surgical and non-surgical back pain can be rather difficult to manage. I believe about 10 to 15% of population in the United States suffers back pain at some point in their lives. And multimodal therapy is often ineffective. And people are seeking out chiropractors, acupuncturists, as other ways to deal with their pain. And the back pain itself is a major contributor to the opioid pandemic. As spine surgeons routinely get asked by patients to, can you give me some Percocet to get me through? And through pain management doctors and primary care physicians, a lot of these patients end up long-term abusers of opioids. And it's been shown it's not exceedingly effective despite its high use. And the medicinal cannabis has recently been legalized in a lot of states here in the United States. As of today, about 35 states have legalized it. And cannabis has been widely studied for pain control. In particular, it's been reported to be effective as pain related to cancer, rheumatoid arthritis, MS, and fibromyalgia. And just my experience here in Seattle, when I first started here and speaking to patients in the clinic about, what do they do for back pain, a lot of them were taking cannabis. And part of it is recreational cannabis is legal here in Seattle. In case basketball fans want to know what Sean Kemp is doing nowadays, he runs a cannabis shop in downtown Seattle. Yeah, you can't drive more than a block or two here. No, I'm joking, but the cannabis stores quite frequent here. It's just driving through town. So it's easy access, and a lot of our patients utilize it. And just quickly asking them, like, what do you think? Do you think this helps? A lot of them really believe that cannabis helps their back pain, or at least makes it tolerable to where they can get to work. So interestingly, cannabinoids work differently through a different mechanism of action than opiates. And it makes it an attractive adjunct therapy potentially. There's two types of cannabinoid receptors, CB1 and CB2. The second type is on immune cells, and it's not pertinent to this talk, but the first receptor is present on presynaptic neurons. And when you bind THC or synthetics such as dronabinol or nabilone, there's about 66 THC derivatives that have been identified. It blocks neurotransmitter release into the postsynaptic neuron. And this has a multitude of effects. You know, people quote unquote feeling high or hungry, but then pertinent for us is can this modulate pain control? So looking at the literature, there seems to be some literature out there regarding back pain. There's a lot on cancer pain, but I set out to do a systematic review to see, is this something that is well studied and something I could recommend to my patients? So our key questions, I had 3 of them, and it's, I'll go through this quickly because we're kind of running out of time, is what is the evidence that mechanistic chemists can reduce pain following spine surgery? Second question is it efficacious in chronic low back pain? Or thirdly, what about patients with post-spinal cord injury, as cannabis has been shown to be have some effect for neuropathic pain? So this is our search strategy. We use mesh terms, cannabis, THC, or other types of medical marijuana, and combined it with low back pain, spine, back pain, surgery, etc. So we searched Medline and Embase, and after the duplicates were removed using our search strategy, we had 1,738 results. We screened these title and abstract and came up with 22 full-text articles that were assessed for eligibility. And then for our actual articles included in the study, we only used randomized control trials or cohort studies. And of all these articles, there's only 4 that met the criteria. Unfortunately, none of the papers addressed post-surgical back pain, but we did have 2 papers that addressed low back pain and then 2 papers that addressed post-spinal cord injury pain. I'm not going to go into the weeds because we're running out of time, but just quickly, I just kind of want to show some of the results we found in our papers. This is the 2 articles addressing low back pain. They're both, one was a randomized controlled trial, the first one, and the second one was a observational crossover study, a cohort study. First one used nabilone, which is a synthetic form of THC, and they showed a significant statistically improvement in pain after the synthetic marijuana for low back pain. And in the second study, they used inhaled THC, and they also showed in 31 patients, a statistically significant improvement in pain control after, I think, 4 weeks. And in both those studies, there was no serious adverse events described. And then looking at our last 2 studies, this is post-spinal cord injury patients with back pain. There was a small study of 7 patients that actually did not show any statistical increase in pain control, but just showed a trend towards it. Unfortunately, it was only 7 patients. It was not powered really to show statistical significance. But importantly, it showed that there was no serious adverse events. And in our last study, this was a randomized controlled trial out of Austria. It had 42 patients, and they used inhaled THC as their form of drug delivery, and they showed significant improvement in pain control. So just to wrap up, there are not many high quality publications about cannabis and back pain. There are a lot of case reports or just observational studies, but through our review of the literature, we were very strict in what we included, and it was, as I showed, there's only 4 papers that met our criteria that were 3 randomized control trials and 1 cohort study. And there are fortunately no articles that address cannabis as it specifically relates to post-surgical pain. In 3 of the studies, it was shown to be statistically significant at reducing pain, with the 4th showing a trend towards pain control. So I think that there may be something to this, that it may help with back pain. But importantly, there's no serious adverse events that were reported. However, the follow-up was short-term. It was only several months. There's data out there suggesting that long-term cannabis use can have deleterious effects on cognitive ability. And also, importantly, the studies did not address pre-existing psychiatric illnesses. There's been shown that cannabis use in patients that are depressed or also schizophrenia or mood disorders have a higher rate of suicide after cannabis use. This is something that needs to be fleshed out. So just based off the review that we've done, it says cannabis may be an effective therapeutic option for treating back pain. However, I don't think that the literature supports, widespread use. But I think that, for most patients coming in, I would not recommend against it, using it. That's all I had is questions.
Great job. So go back to that previous overview with the synapse diagram. So I thought this was brilliant how you educated us all on that there's a separate pathway actually for pain control. So in your studies, were those patients on opiates also, or were they excluded from opiates?
No, they weren't. They actually, most of the patients were on opiates with low back pain, but this was in addition to, they kept their.
So this is supplemental. So, okay, exactly. That's important. Yeah. Is it an augmentative effect? Is this a kind of an augmentation effect that you can see?
To the opiate theory, I don't know. That wasn't addressed in the papers.
I thought this is a really important project that you took on. I congratulate you on it. This certainly offered insights that we had not anticipated. How would you approach this now to go forward? Would you have a large prospective study, or would you ask pharma to run this kind of a study? How would you formalize it? The level of evidence becomes more robust.
Yeah, I think a prospective study would be great. I'm where I took a job at. Recreational cannabis is legal as well there. And I was just thinking that there's so many patients that come in that are already using this. Would be easy to study in a prospective way.
What would the ideal administration form be? Oral, inhalation, injection?
Based off again, there's only 4 studies here. The 2 studies that use inhaled THC had a better effect. That interestingly was not dose dependent. So that may be the best form. However, some patients don't tolerate that well. Patients with pre-existing, lung conditions. So another option would be that's probably easier studied would be oral form, oral THC.
So thanks for that study. Dr. Heyman. Can we switch the screen to Dr. Heyman again? Eric, are you on?
Yes.
So all political discussions aside, in Florida, is THC legal at this point in time? I actually don't know that. And what are your thoughts on hearing Rick's presentation on THC as an alternate pain modulating agent?
Well, I mean, in terms of legality, for medical purposes, it appears to be legal. I don't know the formal legal status, but a large number of patients report medical marijuana as the thing that helps them improve. I don't personally prescribe it, but, just incidentally noting, patients report it does help with their back pain. Seeing this mechanistic slide is sort of interesting because you didn't talk about the CB2 receptors, but it looks like it's expressed on astrocytes, which are actually known to potentiate, we don't think of them as a thinking cell, but they actually very closely interact with neurons and are involved in chronic pain, particularly neuropathic pain. And it's been shown that targeting astrocytes, for instance, modulation of SUR1 expression, et cetera, and astrocyte inflammation actually has a very favorable effect on neuropathic pain, the sort of thing you'd see after a nerve injury, for instance. In terms of actually providing recommendations to my patients, I tell them, if it controls their pain, it controls their pain, but I can't really recommend for or against it. Just especially in at least the preoperative period, I do ask them to stop it just because, one, it complicates their anesthetic plan. Again, that's not something I could cite in literature on, but talking to anesthesiologists at Cherry Hill, et cetera, they will say patients who are chronic marijuana users have a significantly more complicated anesthetic and postoperative course. And the other issue is we know it has effects on the vasculature. I think we're starting to see evidence of aneurysms in young patients, vasculopathy in younger patients who have no tobacco use but use marijuana. Again, breathing in a bunch of tar is not great. Now, whether this applies to edibles or vaporized THC or other forms is a different story. But I think, we know smoking is bad for you. We think it's nicotine, but we don't know that. And until we know that, in my view, it should be treated in the same category as tobacco smoke.
Great thoughts. That was news to me that there are maybe more angiopathies or aneurysms. Rick, CBD has become a very common supplement, and both of our academies, AANS and AUS, have kind of written surprisingly favorable position papers on this. Does CBD go through a separate pathway? Is that kind of a similar receptor?
It's a separate pathway. It's actually not in the cannabinoid. That's why we were going to include it in the study, but because it works differently, we did not include it in the systematic review. That's interesting that they've both endorsed its use, because the literature is not there. Because I was actually going to look into doing a second systematic review on CBD, and there was even less high quality literature out there than there was for cannabis.
I was very surprised by that myself, because again, I did not do closely to the depth of literature that you had, and I was completely caught unaware of that. But maybe they just wanted to be hip and go with the times. Well, thank you for your project. Eric, take us out of here. Come a little bit closer to the camera so we see you better. So final 5 minutes of what you've learned in your first year of academic practice in neurosurgical spine surgery, and words of wisdom for the